Muted.
Manager of Patient Programs at Crohn's and Colitis Canada. I'm very pleased to have the opportunity to moderate today's webinar called Looking Ahead, the Future of IBD Treatment with guest speaker Dr. Brian Bressler. This is the second webinar in the Youth Education Series hosted by Crohn's and Colitis Canada and supported by AbbVie. A bit of background, Crohn's and Colitis Canada was established in 1974 by a small group of concerned parents, children with Crohn's and colitis. Now we are a national charity with more than 65,000 supporters and 80 volunteer groups and chapters across the country. Our mission is to find treatments and cures for Crohn's disease and ulcerative colitis and to improve the lives of children and adults affected by these diseases. Crohn's and Colitis Canada has funded over $88 million in research to date. That makes us one of the largest funders of Crohn's and colitis research in the world. Some housekeeping items. All participants are muted so everyone can hear the presentation clearly and we can record it without audio interference. If you have technical difficulties or would like to ask questions during the webinar, you can type it in the chat box on the right side of your screen. For your questions, we will make note of them for our speaker to address as many as he can at the end of the presentation. We have allocated 1 hour for this session, and the agenda includes 40 minutes with Dr. Brian Bressler, our medical expert, and 10 minutes left at the end for everyone to have the opportunity to ask some questions of Dr. Bressler and a short wrap-up at the end. So now let's get started by introducing our clinical IBD expert, Dr. Brian Bressler. Dr. Brian Bressler is a clinical associate professor of medicine in the Division of Gastroenterology at the University of British Columbia's Department of Medicine. Dr. Bressler is the director of the Advanced IBD Training Program at the University of British Columbia. He received his MD from UBC and completed his residency in internal medicine and gastroenterology at the University of Toronto. He received his master's in epidemiology from Harvard Public School of Health and completed an advanced fellowship in inflammatory bowel disease at Massachusetts General Hospital, Harvard Medical School. Dr. Bressler is a recognized expert in inflammatory bowel disease. He has received the Canadian Association of Gastroenterology Young Educator Award in 2015, top reviewers of 2010 and 2015 for gastroenterology and clinical gastroenterology and hepatology. His research interests include population-based studies, classic clinical epidemiological studies, and clinical IBD. Please take the floor, Dr. Bressler. Thank you very much for being here.
Great, thank you. I really appreciate this opportunity and certainly look forward to spending the next hour with everyone remotely on this webinar. So it's not always the easiest venue to have a discussion. Certainly hope though there will be some opportunity towards the end to have some back and forth question and answers. When thinking about appropriate questions to answer, what I always ask of people when I have the opportunity to speak is to try to think of questions that you want to answer that would be relevant for everyone on the call. Certainly there would be other opportunities to potentially explore personal issues with regards to one's own condition or condition of a family member or friend, but probably not the right venue for that sort of discussion at the end of this talk. So, I don't have to do it twice. Okay. Here we go. So the future of IBD treatments and what it means for you. So without a doubt, I can say confidently, I've been practicing now for 10 years. This next year, if you kind of take it from 6 months ago to 6 months from now, so we're kind of in the middle of it, but I would confidently say that the most changes from a medical point of view will occur over these 12 months than they have in the last decade, which is really exciting. It gives potentially opportunity for patients who have either not had appropriate responses to therapies to date to try new ones, but also it's an opportunity for patients to potentially be given an opportunity to be on newer medications that have some features that are unique to them and may not have the same issues that some of the older ones do. So my intention today is to discuss three of those sort of themes. There's two medications and one kind of strategy, which we're going to review. So the first one, so kind of going in chronological order in some respect, is a new class of medications. So there's a drug that's approved both for both for ulcerative colitis and for Crohn's disease. And I think if you want to call it the selling feature, the attraction that this sort of therapy could potentially have in a patient, for a patient, really relates to what it's doing. And I'm going to spend a little bit of time now kind of going over and trying to, as clearly as I can, explain how this medication works. And it's very, very different to how any other medication would work that we have so far for Crohn's disease or ulcerative colitis. And it's actually a class of medication. So there are multiple ones that have, obviously each medication has their own unique characteristics. But this class is called the selective leukocyte adhesion molecule inhibitor. Very fancy name. But when I show you these slides, you'll actually see how simple it is as to what it's doing. So the basic idea. So what you're seeing here is what is happening now routinely. So at the site of our gut, so that's the gut lumen, that's being exposed constantly to our food and to bacteria. There's our own bacteria that live there. Then you have this layer in between the blood vessel and the gut lumen, and that is where all of the action happens. That is where, if you had inflammation, where you would have damage to your bowel, it would all occur in this area called the lamina propria. And what causes the damage potentially are these lymphocytes. These are our white blood cells. So these are cells that they're our policemen in our body. They are designed, they get called upon when there's a problem, and they're designed to put it out. So what can happen here is, for reasons that aren't entirely certain, but if you can see that protective barrier at the top there, so where you have all of these potential antigens would be kind of, you want to call it criminals. They're things that are going to create a response or should create a response. So I'm sure many of you have heard of this leaky gut phenomenon. So you're seeing here is the leaky gut. So you're having more of these bad guys come into this area that can potentially cause problems. And then you have, I would call these kind of the scouts. These are the ones that are always there, and they're kind of looking for problems. And when they see a problem, they're the one that they call 911. So by calling 911, so what you can see here, we call this an antigen-presenting cell. It's processing these bad guys and saying, this is the problem, we need help. So by calling we need help, it releases many different substances. So this is the number one, is these watchguards sampling the bacteria, presenting it. And one of the actual substances that it releases, we call those cytokines, is actually TNF-alpha. So one of the ways drugs like Remicade and Humira works is by interfering with this particular process, because it interferes with the production of TNF-alpha. So it will kind of dampen down that immune response. What's, though, different is that it'll have many effects, not just this. Whereas what we're going to talk about right now only will work on this. So what we're going to focus our attention is the understanding that this is really a good phenomenon. What you want here is, you want, when you have an insult come into your body, you want to be able to deal with it in an effective way. So just following this through, going to number 4, the way you open the door and you allow the policemen and the white blood cells to come into the site of damage is by these very unique things called adhesion molecules. So adhesion molecules are proteins which are expressed on the side of the blood vessels. And they're going to be now expressed much more because of the stimuli that you're getting. So what you get here, maybe I'll just go back for 1 second. So what you get here is, through that marker, you then get these lymphocytes, so these white blood cells, to come into the site of attack. And that is exactly what you want when you have, like I already said, a foreign invader. So the classic example would be food poisoning. So you have raw chicken, you have salmonella poisoning or campylobacter poisoning. You have a problem you got to get rid of. So when this process is working properly, it does what it needs to do and it goes back to normal. One of the theories as to what Crohn's disease or ulcerative colitis would be is when you have this constant call-up of those white blood cells inappropriately, that they shouldn't be so in demand. That if they were just turned off, we wouldn't have a problem. But this is what Crohn's disease and ulcerative colitis is. So what you see here on the bottom is all of these sticks that are now being presented. They continue to be expressed. And what you can see here quite nicely is this process of the white blood cells, the lymphocytes, squeezing into the site of inflammation. And the problem is when they're there, they're causing damage. And if you had a little bit of damage for an infection, you get rid of it and you're done. But this is a persistent, continuous problem, which is one of the models of what happens when a patient has Crohn's disease or ulcerative colitis. So focusing in a little bit more of how that interaction is. So very specifically, the lymphocytes, so these are the white blood cells, they express this is like a lock and key phenomenon. So it has a key on its surface. It's called an integrin. And when it joins up with the adhesion molecule expressed here, that's the lock, I guess. You have that intimate interaction, which then forcibly pulls the lymphocytes into where they need to be. And what's very unique, and probably the most important point about it, is that these lymphocytes that express this particular key are unique to the GI tract. So every part of your body has their own key expressed on their lymphocytes. So you have lymphocytes that are designed to go to your skin, to your brain, to your joints, everywhere, including your gut. And we know where they go based on what they are expressing, which key they're expressing on their surface. So what this new mechanism of action does, what this new drug does, is it goes after this particular idea. So this is the drug. It's called vedolizumab, or the trade name is called Entyvio. And what it does is it blocks that key. It does not allow that key to interact with that lock. So by doing that, it does not allow these white blood cells to go where they are programmed to go, which is exactly what we want to do, because by doing that, you then create an environment in your bowels that are no longer being continually damaged, and it allows your bowels to heal. And if you continue using it and you continue to have this process, you won't have that damage caused by these white blood cells. And what's so special about this is this idea of how specific it is. So another analogy I give a lot is if you think about your bloodstream is a highway, and each car has its own kind of GPS, and they are programmed to get off at certain exits. And for the gut, let's say that's exit 17. The blood cells, the white blood cells that are programmed to get off of that exit, they can't get off. There's a blocking to the exit. That's vedolizumab. But what's unique is that that doesn't impact any other part of the highway system. So the idea and the real advantage of it is different than other biologics we use, is that the rest of your body's immune system is not impacted by this particular medication. Now, this is the theory and the science, and we've been looking at it, and so far it seems to be true. We haven't really seen examples of a compromised immune system leading to complications outside of the GI tract. And yet, we'll show you now that it works in controlling the inflammation in the GI tract. So this has been a story, and I present this not to go over each detail of it, but to highlight the fact that when a new drug comes to market, it is new, and certainly we don't have as much experience as we do with other drugs that have been on the market for a long time, but this drug has been in development for a long time. Particularly, what's also very unique, this drug was discovered in Canada. So many of these early studies in the 90s were done in Canadian patients. So we actually, in Canada, have been using this drug in various ways for almost 20 years. Granted, not to the same numbers as we've used other drugs, but in some respects, this isn't that new of a strategy for us in Canada. So I think I'm going to skip this slide. So to prove what I just said, so I tried to show you in a pictorial way that this drug will interfere with the immune system of the GI tract, which is what we want, but won't interfere with the immune system of the rest of your body. So this is a study that tried to address that. So what it did it gave patients this drug, but sorry, not patients. It gave healthy volunteers this drug. None of these patients had inflammatory bowel disease. They were all given one dose of Entyvio, but a very large dose of Entyvio. And right after that, they were then given the vaccine for hepatitis B. And you can imagine the hepatitis B vaccine relies on your body's immune system outside of your GI tract to work. And they also gave these patients the oral cholera vaccine. So that's to prevent a diarrheal illness. So that's particularly relying on the immune system of your bowels. If this drug was really doing what we thought it would do, we would potentially anticipate a different response to these different stimuli. And that is what we saw. So compare, and then the other obviously important point is that half these patients were given placebo. So if you look at the seroconversion rate, so the ability for these patients to become immune to hepatitis B, there was no difference whether they were given vedolizumab or nothing. Kind of suggests the fact that indeed it's not interfering with the immune system outside of the bowel. But there was an attenuation when you gave vedolizumab to the cholera vaccine. So this is an example of looking at the ability to form antibodies to cholera when given that vaccine. You can see for the placebo, the orange, it worked, not so much for vedolizumab, suggesting that you have this disconnect. You have the impact of the immune system of the GI tract, but not of the rest of the body. And that's exactly one thing we'd be looking at to try to make a safer form of therapy for patients with Crohn's and ulcerative colitis. And in a similar example, just a different antibody they looked at for cholera. All right, so that's all fine and dandy. I can tell you that it's safe, but it's absolutely useless if it doesn't work. So is there any evidence to suggest that it's actually going to help? Well, you can imagine we wouldn't be talking about it unless it was, because Health Canada wouldn't have approved it unless there was evidence. So what you're seeing here are examples of really the pivotal trials that looked at vedolizumab or Entyvio for ulcerative colitis. And there were various endpoints they looked at, and really, I don't think tonight is really about the discussion, the details of these endpoints, because there's a lot of details that would have to be explained to truly appreciate the meaning. But to show you, half the patients, not half, but some patients were given placebo, majority were given Entyvio, and this was after only 2 infusions. So the way Entyvio is given, it's given similar to Remicade as an infusion. But what's different is a very quick infusion. It's only a half-hour infusion. And it's given at time 0, 2 weeks later, 6 weeks later, so 0, 2, and 6, and then every 8 weeks thereafter. This assessment was after only 2 infusions, but at week 6, right before they got their 3rd infusion. And about 50% of patients had a response, which is a respectable value. You wouldn't anticipate that you would have got into remission, where remission is a much harder thing to get into so quickly. But the other encouraging thing was how many patients actually had healing of their bowel when they looked so quickly after starting Entyvio. So a very strong signal that this drug is indeed effective for ulcerative colitis. We broke up, it was also, and I could spend 3 hours showing you slides on data, but I think another important point to make though, and this is very similar to any biologic I were to show you, was that you are most likely to respond to the first biologic you've received for various reasons. And that's both for ulcerative colitis and Crohn's, probably more relevant for Crohn's. So what this is doing is actually showing that. So in patients that have never been on a biologic, so that would be patients without anti-TNF exposure, their response rate looked different, looked better than if you've previously been on an anti-TNF agent. So you see a response rate, if you've been on one, of 39% versus 53%. Just a message that, and the other thing we know just by kind of data when we follow patients for years is that you are most likely to stay on the first biologic much longer than once you go to the second instrument. That's not obviously always the case, but a general trend we see in many different data sets. So the next slide here is looking at patients who have responded, but then also the next question we want to know is, well, is there any value in continuing the drug? We know in general, we know we don't have a cure for Crohn's or ulcerative colitis, and we know that most of the drugs we use have value both in getting patients better and keeping them well. And that's what this is looking at, that patients that have responded, how likely are they to be in remission a year later? So this is an example at 52 weeks. And you see these values, again, really strongly support the efficacy. Now, one may ask, you know what, 40, if you look at clinical remission, 44% doesn't sound that good, and I agree it doesn't. I can tell you, compared to the other drugs we use, like Remicade, it's as good, if not better, than any other drug we use in the trials, because we know that these drugs do perform differently in the clinic, and there's many different reasons why the data for the clinical trials don't reflect accurately what will really happen in the clinic. So that's ulcerative colitis. This drug has also been evaluated for Crohn's disease, and the message is similar. Just, I think, probably one point to note, and I don't know if it's true or not, but certainly the signals suggest it. So I'm just showing you one example of a trial, looking at the value of Entyvio for Crohn's disease, and then the endpoint here that I'm showing you is remission. So that's a really, really hard endpoint to receive. That means the patient is feeling as if they really don't have Crohn's disease. And the message here that, if you're familiar with Entyvio, you probably heard it, is that it does seem to potentially take a little bit longer for Crohn's disease than for ulcerative colitis, because you see where the advantage really starts to be apparent in the patients on Entyvio is at week 10 as opposed to week 6. There is a difference compared to placebo at week 6, but if you can see, the placebo rate actually doesn't change as you go longer, but you're really seeing this drug kick in a little bit. And it kind of makes sense if you think about the mechanism of action that I talked to you about. That what I was showing you is that all it's doing is not allowing the white blood cells to get into the site of inflammation. What it's not doing is actually having an impact in the site of inflammation itself. So I would think it just needs to take time for the cells that are already there to kind of burn out and stop doing what they're doing. But during that entire phase, not allowing newer cells that will cause further damage. So I think the time lag, in my kind of simple mind, does make sense as to why it's like that, though interestingly we don't see that for ulcerative colitis, but we do for Crohn's. Again, same message with regards to, okay, it works to get patients better. How does it work to keep patients well? And you could see here that the signals are similar, that if you, and I should have maybe explained, so what you're seeing are all patients got vedolizumab, because these only patients that went into what we call the maintenance arm of the study are those who responded to vedolizumab. And they were randomized to get nothing, to be given it every 8 weeks or be giving it every 4 weeks. And there was no difference that a patient did any better if you got it every 4 or every 8 weeks, but there was a difference if you just got placebo. Okay, so the last part of Entyvio is to now try to really appreciate if kind of the test tube laboratory data converts into real-world human data. So I think it's quite obvious that the advantage of this drug isn't necessarily the efficacy. It works as well as other drugs, or it probably works as well as any other drug we have, but so what? We have drugs that work like that. Where it could potentially offer an advantage to a patient is its safety. Is that the reality is Crohn's disease is when one's immune system is inappropriately turned on. So in order to respond to that, you have to control that immune system. But if you control the immune system only at the site of where you want to, that being at the GI tract, and preserve the immune system everywhere else, then what you would potentially lead to is a state where you're beneficial for the patient and that you're not exposing them to infections. And that's really the risk. There's obviously very rare risks of other things, and I don't want to downplay them that much, but the reality is the risk in general of this idea of treating Crohn's disease is a risk of infection because your immune system is somewhat compromised. So, and then the challenge when proving safety is we always want more time. We always want more patients on the drug. We're never really satisfied with 5 years. We want 10 years. We want not 5,000 patients, we want 50,000 patients. We want it, the bigger of an experience we get, the more confident we will be really what are the risks. And we think we all have to draw our own line as to how much data are we going to look before we say, yeah, this drug is safe, or yeah, this drug isn't. And that literally is time we have to give. So this is fairly recent data, but this is looking at now over 2,800 patients. These were all done in the clinical trial. And the advantage, obviously, of getting a value in a clinical trial is how carefully these patients are being followed. I don't know if any of you have participated in a clinical trial, but there's a lot of visits where it's very different if you try to capture infectious rates, let's say, in your clinic, because you may get a cold, you may even get pneumonia, and you're not going to tell your gastroenterologist about it because you're not going to see them for another 6 months. So by the time you see them, you forgot to even mention it to them. The clinical trial, you ain't going to miss it. You're being followed like every month. They're asking you questions. You're going to capture something if it's there. So these are complicated slides, but I just want to draw your attention to here. So because, as you can imagine, in a trial, there's less patients on placebo than on vedolizumab. So of course, you're going to have less events in the placebo group because there's just less of them. So you have to standardize that, and we call that by giving it a rate. So here we call it 100 patient years. So you can see the risk of any adverse event is higher in the placebo group than vedolizumab, and any serious adverse event is higher in the placebo group versus vedolizumab, which is not that uncommon in an effective drug, because the number one adverse event usually in the placebo group is an exacerbation of their Crohn's, making their IBD worse, which you wouldn't get as much with vedolizumab. Where it gets a little bit more, I would call it exciting, is here. So here you're looking at infection. And if you look over here at any infection compared to placebo versus vedolizumab, not only is it not more with vedolizumab, but there actually is suggestion in this data set that your infection rate is decreased compared to the placebo group on patients on vedolizumab. So why would that be the case? Well, probably why it's the case is because the number one drug to cause infection in what we use in IBD is prednisone. So if vedolizumab works to the point where you don't need as much prednisone, and I went very quickly through those efficacy slides, but both Crohn's and Ulcerative showed that your chance of being off prednisone was higher in the vedolizumab group because you're doing better. So if you're having less prednisone exposure in the vedolizumab group, you kind of have two things going for you. You're on a drug that doesn't necessarily cause much in the way of infection, or if at all, but two, you're reducing the exposure of prednisone, which is why potentially in the placebo group, you're seeing higher infection rates. We've never seen that relationship in any of our biologic clinical trials. So a real strong suggestion that that theory that we've spent so much time talking about already tonight is being seen in trials, which means it will likely be converted to clinical practice. You could also see with the other important point as well, I showed you how the cholera vaccine didn't work quite as well in patients on vedolizumab. What about gastrointestinal infections? Should there be a worry there? And I could think quite rightfully there could be a reason why we should be concerned. It hasn't yet shown up. So the only one seen here is the C. diff infection rate, and we don't see a difference. But again, that one you can argue maybe it's a little bit too early to be certain about that. But there wasn't a signal in this particular trial. So just the conclusion of the study, which is fairly new, and this was based on 5 years, a lot of patients, and it's not associated with vedolizumab with an increased risk of serious or opportunistic infections. And other sort of events occur very infrequently and nothing more than the placebo group. And it further emphasizes the favorable benefit-risk profile of vedolizumab for patients with IBD. So that was my section on Entyvio. So where are we at now in Canada with Entyvio? So Entyvio is approved for Crohn's and ulcerative colitis. It's not on anyone's formulary. So there isn't, I'm not aware of any public funding for it yet. I think some private insurance companies are picking it up, but the reality is all of these biologics and the companies that make them have a very, very robust compassionate program. So if this is an meaning, and a compassionate program means that the drug company will give the patients the drug for free if they meet criteria, and they'll continue to give it for free until it then becomes available for them through their public formulary. So through whichever province you live in, they'll hopefully eventually cover this medication. But that always takes time. That takes probably in the context of a couple of years before we'd anticipate that. So that's something to consider, and certainly you were talking, and I would be very surprised if there isn't a gastroenterologist in this country that isn't familiar with this opportunity. Okay. So, oh yeah, just 2 other slides about pregnancy. We don't know if it's safe for pregnancy or not, in that we haven't had as much experience, but the FDA, which has this very, it's pretty archaic, but it has a way to kind of classify the safety of drugs in pregnancy, puts it in the same level as Remicade or Humira. And we feel quite confident that those drugs are safe to be used in pregnancy. Vedolizumab, according to the regulatory bodies, would agree that that's probably the same safety profile. And in Canada, in our pregnancy consensus statement we put out, is that it really may be a reasonable option to consider during pregnancy, and we kind of left it kind of vague. Okay, so that's drug number one. Now, I would be excited if there was only one drug new, because we haven't had anything new in so long, but not only is there one drug, there's a second drug that's coming. So this drug is certainly coming to Canada. I don't think I could tell you exactly when without breaching confidentiality, but I would tell you that the FDA approved it in the United States for Crohn's disease about 3 weeks ago. So I think quite soon this medication will be available in Canada for the treatment of Crohn's disease. So this is a drug called Ustekinumab. The trade name is called Stelara. Stelara is already in Canada, which makes it nice. So there's already experience with it, but it's used for different conditions. It's used for psoriasis and for psoriatic arthritis. And there's a lot of experience with it. And I've heard that many dermatologists say this type of therapy is the best therapy they have for psoriasis. So we're pretty excited that we'll get an opportunity to use it for Crohn's disease as well. And I'll show you some of the data that led to that recommendation. This is a slide kind of explaining what it does. And I wish these other drugs can be as kind of elegant in explaining what they do as the Entyvio slides do, but unfortunately it's much more complicated. Complicated doesn't necessarily mean it's worse, but it's just harder to convey what it's doing. But it's blocking those signals. So I would actually equate what this drug is doing similarly to what Remicade or Humira is doing, but with a different, it's blocking something different than those drugs, but blocking it in a very similar way. So there were 2 studies that looked at the value of using Stelara for Crohn's disease. And there are some very unique features of this drug, which is highlighted here in somewhat of a complicated slide. So the first one, which is kind of cool, the way the drug is thought to work best to get patients better. This is for Crohn's disease, not for psoriasis. Psoriatic arthritis is different. But for Crohn's disease, it was thought, and it will be such, that your first dose is going to be an infusion. You're going to get one infusion, and only one infusion. And then about 8 weeks later, you're going to get an injection. And then after that would be like an injection like Humira. And then I'll show you data to suggest that it was looked at then continuing that injection either every 2 months or every 3 months. So thinking about, okay, well, what is this drug? Why are we excited? What's new about it? The idea that going forward after that first infusion, that a patient would only have to take 6 or 4 injections the entire year makes us all extremely excited with regards to the minimal impact it will have in a patient's life. And we understand that one of the big issues about having Crohn's and ulcerative colitis is that impact that it has. That it would probably be even better if one had a pill, but then a pill would likely mean you'd have to take it every day. But if we could create an environment, if we can offer a patient a strategy that can be used so infrequently, but yet deliver the value that the other drugs do already, we think that's a huge advantage for a patient. We think that the impact it has on their quality of life will be immense because they won't have to worry about constantly having to do something. And I think that this drug potentially offers that value. Now, that's providing it works, so let's talk about that. So the initial 2 studies to look at the value of it working in a patient who has active Crohn's disease is the first set I'm going to show you. So it's displayed differently than the trial I showed you last time. So what you're seeing here, again, are 2 different set of patients. And again, this again speaks to the value of the first biologic you use, the most likely it is to work. You have patients who have previously failed an anti-TNF agent versus those that haven't failed an anti-TNF agent, so have never been on a biologic before. And you see, strikingly, how much better it works in those who have never been on a biologic. But what I want to highlight are 2 points. So the first point is how quickly this drug works. That you're seeing, compared to giving placebo, already a separation of significance after only 3 weeks of therapy, which really is quick. That really does, we haven't seen data that's quicker. Maybe Remicade works about as quick, but the time of onset is very, very quick. then the other reality is how high the response rates are. That these values are higher than values we've seen with any other drug. But it just may be the way the trial is designed. I'm not suggesting it's better than any other drug, but I think it gives us confidence that this drug truly is effective for Crohn's disease. And then just another example of how quickly it potentially works. So this is one of the measures we look at to assess whether a patient has active Crohn's disease or not is how high is their CRP, which is a blood test for inflammation. And you're seeing here how quickly you get a reduction in that CRP, which goes in keeping with the slide I showed you before of how quickly they responded. Another endpoint, which we'll just move on, and I wouldn't want to necessarily compare one drug to another because I offer many things it's not good to compare, but if you do remember the Entyvio data I showed you, that the remission rate at week 10 was about 29%. And here you're seeing a remission rate for those who have not been on an anti-TNF agent before about 40% and about 20% to those who are on anti-TNF agents. And I would say, though, that 29%, that about 40% were on TNF agents. So it's actually kind of a mix of the two. So it does actually kind of fit quite similarly. That we don't like to compare between because that's not why they're designed, but you're showing that this drug, like Entyvio, really is effective for Crohn's disease. So the other value, so I showed you it works, and then if you have responded, how are you going to do if you continue taking it? So you're seeing those patients who only got the drug and then nothing else for a year. Some patients got this injection every 3 months. Some patients got this injection every 2 months. And you can see both of those strategies were effective. And these rates, if you remember the rates I showed you before, they're very similar, 40, 50%. Not that common, though, you see 50% response rates. And you're seeing that in with this particular medication. So that was all I have for Stelara. We have one of the nice things about it, and we were learning a lot from our dermatologists, is how it's been their experience. Like I've already commented on that, the experience has been positive. That they really find there's been tremendous value in this drug for their patients. We are as hopeful that it is as well for Crohn's. And the other reality is again, through these compassionate programs, which are fairly unique in Canada, we have a lot of experience with Stelara. I could confidently say I don't think there's any country in the world that had more patients on Stelara compassionately than we do in Canada. There are some sites, there's about probably, I'd say 5 to 6 sites in Canada that have a lot of experience with it. And our experiences, and I'm included in that, has been very positive. So we're really excited to be offering, if given the opportunity, to offer this to patients in the future. All right, so this is all great. Who's going to pay for all this? So my last couple of slides is talking about, which I don't know how interested you guys are going to be on it or not, but I want to introduce this concept if you haven't heard about it yet, because it is coming, and we need to kind of wrap our heads around what is its implication. So the first thing is to understand that this is fine and dandy that we're offering these medications. The reality is these medications are costly. They cost our healthcare system a lot of money. We think there's value in spending that money because we understand, and so do the people that pay for it. So the politicians understand that these medications, though costly, are really beneficial for their citizens. That they're the people that they are responsible for in their constituencies, they need these medications to have such an impact in their quality of life in a positive way. But it's costing a lot of money. So with that understanding it, we need to see if there's ways to reduce the cost. And one of the ways to reduce the cost would be to introduce and start using medications that are cheaper. And as I'm sure, I think probably you all know, that after a certain time frame, and by no means I'm an expert in this, but at a certain time on the market, the drugs are no longer protected. The patents wear out, which means that you can then, if you want to copy the medication, and those are typically called generics, which you're all familiar with. The term when you copy a biologic is a biosimilar, and it's because these medications, I want to see if I have a slide, yeah. So these medications, this is comparing generics to SEBS, which are biosimilars, subsequent entry biologics. They're much larger molecules, and they're not made in a test tube. They're made actually in a living system in cells that produce this, And because of those facts in particular, you cannot completely replicate the agent. It's just not possible. No one would ever admit that it's possible. They know they can't. So you have to try to make a drug that's similar, not identical. And then with that, once you have it, you then need to figure out, well, is it really behaving the exact same way as the original medication is? And if it is, then we would use it. And if it isn't, then it wouldn't be allowed. And Health Canada has a very, very well-defined process in trying to evaluate these drugs and say, yes, this drug really does seem to be similar because of whatever that they decide is, and this one isn't. So that, and then once that's the case, then you have an opportunity potentially to use a drug that's not the same as the other drug, but similar, but yet much cheaper. So that's what we're beginning to deal with. And this is just an example of when we talk about how complicated they are. So comparing aspirin, this is just a measure of size, 80 Daltons versus 30,000, which is erythropoietin, which kidney patients use to increase their hemoglobin, to 150,000. These are really monsters when we talk about the size of a chemical, of a drug. Very challenging to replicate, not possible in fact. And one of the issues which we are wrapping our heads around is the way we evaluate new drugs is similar to the discussion we've had tonight, is that we talk about how they performed in a patient with Crohn's, in a trial with Crohn's disease, ulcerative colitis. We looked at how effective it was, how safe it was. That's not really what Health Canada looks at for these drugs, because that has already been done for that molecule. They are much more focused in ensuring that they are similar enough to the original molecule. And the challenge with that for us as clinicians and for you as patients is that we don't have the expertise, or I assume most of us don't have the expertise, to really understand what those types of studies are, because these are very, very complicated basic science studies. So because of that, I strongly believe that we need to rely on the experts, and those experts are those at Health Canada, and they will tell us, and it's our responsibility and our duty to question them if it's done. But we have to understand that they really do. They're doing their best to try to figure out, is this drug similar enough, and how should it be used? Not just if it's similar enough, but in which patient should it be used in, and in what context should it be used in. So the first one is this idea of extrapolation. So extrapolation means that the drug, the biosimilar, has been studied in one disease, but because it that disease similarly to the real drug, so if you want to say let's say the real drug, so if it worked similarly in that disease, and it was so similar in any way you looked at it with regards to its composition and the way it's performing, you can then say it would be reasonable to use it in any of the diseases that initial drug, the real drug, was proven to be effective and safe. That's the concept of extrapolation. So that would be the idea, and as it stands right now, there's a drug called Inflectra. Inflectra is the biosimilar of Remicade. Inflectra has not been studied really well yet in Crohn's disease or ulcerative colitis, but despite that, it was studied in rheumatoid arthritis and ankylosing spondylitis. Because Health Canada felt that this drug was similar enough to Remicade, and performed as Remicade did in their trials for those conditions, it would be reasonable to have it also used for Crohn's and ulcerative colitis. I can't tell you if they're right or wrong. That's what Health Canada did, and that's where they're at. But there's another part of the discussion that's really important, and that's interchangeability. So I said Health Canada is going to give us guidance with regards to in which patient should it be used in what conditions, I should say, it should be used in. But the next part of that discussion is it reasonable or not to, when a patient is doing well on a drug like Remicade, is it reasonable for that patient, for cost savings purposes, to then switch from Remicade to Inflectra? So that your patient's on Remicade for 5 years, they're doing great, life was miserable before, it's fantastic now. Should you then have to then be on the cheaper version of it? And without going into the details of it, there are some theoretical reasons why that may actually not be a safe decision to be made. We don't know one way or the other, but what's important, again, is coming back to what Health Canada has told us. Health Canada says it's reasonable if you're going to start the medication to use it for other conditions beyond those that have been studied. But they say that you should not interchange this drug. And that's a very, very contentious point that we'll have to see how this plays out, to be honest with you. Because people like me and the Crohn's and Colitis Foundation, with guidance from their Scientific Medical Advisory Board, including, and I'm on it, so you have full disclosure there, we feel that this is a decision with regards to changing the medication that really we should not be doing until we have better data, and ultimately until Health Canada says, yeah, it's okay to do it. Because it would be so shameful if we got a patient who has done well, who's no longer doing well, simply because we switched their drug. Understanding that that does have implications in cost, that keeping them on a more expensive drug will cost the system more, but we think it's worth it at this time until we understand really the issues about switching the drug in a patient who's doing well. All right, so my concluding slide, and then we have some time for questions, is that I think we really do potentially have it. This really, as I said, this is an exciting time. We got a lot of new things coming for have came so far. Potentially safer and more convenient options are now to be considered. Particularly, we spoke tonight about Entyvio and Stelara. There's some other actually drugs that have been approved as well, which we didn't get into. And then I think I wanted to introduce to you this idea of biosimilars, because if you haven't heard about it, I think you should, because I think it's something that will start to become a little bit more out there regarding the press, and it will be an issue that you may be talking to your doctors about. And I don't know where it's going to end, to be honest, but I think there are some there's some terminology and some definitions that I'd like you to understand, so that you can be as well involved in this conversation. Thank you.
Thank you very much, Dr. Bressler, for your informative presentation. We have a few questions for you, which I'll moderate, if that's okay with you. Does the vedolizumab not prevent white blood cells from reaching areas of the GI tract where they are required? That is, where the mucus has been disrupted to an outside source, such as bacteria?
Yeah, so just to make it simple, I described it as white blood cells, and that is an oversimplification of it. That actually, it's really only very certain parts of the white blood cells. So there are many different types of white blood cells. There's neutrophils, there's lymphocytes, and the reality is most acute bacterial infections would be, so the part of the immune system that's required to fight off the bacterial infections are neutrophils. That does, and including C. diff actually, which is why we're not seeing a signal with C. diff. That does not get impacted with vedolizumab. Vedolizumab specifically targets what are called T lymphocytes, which is a very specific part of the immune system. And actually, maybe, can I just, do I still have power here? Yeah. Let me just go back just to that point, the one slide I skipped. I just want to show you how, I'm just going to go back. Oh, it was safety here. Yeah. No, sorry, it was back here. So this slide here. So this kind of gave that example. So this looked at not just all white blood cells, but it looked at, because there's also, although I said there was T lymphocytes, there's many different types of lymphocytes as well. And what you could see here, so if you had a drug that really did limit a lot of the immune cells, so it didn't allow them to leave the highway, you would have anticipated, if you checked in your blood count, that you would have more of them once given the drug, because they're just staying on the highway more. The traffic on the highway is going to increase. And if you look at the first, it is the graph on the right first. This was a drug that's similar to vedolizumab, but what's different about it is that it doesn't only impact the GI tract homing cells, it also actually impacts cells going to the brain. So because of that, it's actually effective for multiple sclerosis. But because it was having a more broader impact on the lymphocytes, you saw actually an increase in the patient's blood count, in their lymphocyte count, after they were given natalizumab. But for vedolizumab, you saw nothing, that you saw no impact. And in fact, people have talked about this before involved with the discovery of this drug, is if we knew before how minimal impact it was having in one's immune system, we actually wouldn't have ever anticipated it would ever have worked for Crohn's and ulcerative colitis, because it was really impacting such a small percentage of one's immune system, of one's immune cells, even those going to the GI tract, because the majority of them actually are protected. But there's this one class that they happen to have discovered that really was driving Crohn's and ulcerative colitis.
Great. Here's another question for you. Although the drugs play a role in lymphocyte migration in the GI tract, the other receptors that would be present in the GI tract would also need to be addressed because they wouldn't cause a pathway to inflammation in the GI tract, correct? So would it be the best to do a combination therapy treatment to target more than one step in lymphocyte trafficking, further increasing the chances of lowering inflammation and lowering the risk of being exposed to immune disease by looking at all receptors in the GI tract, etc.?
Yeah, I mean, I think that's a good hypothesis. I mean, I think that in some respects, you want to be as targeted as possible. That, you know, and the reality is, why does prednisone work in most patients? Because it's kind of, in the way I describe it in a very crude way, in war terms, that's like a carpet bomb. Like it just really deals with everything, but it does it in a way that it really could lead to risk, whereas these are much more targeted. So certainly, if you get more aggressive and target more signals, you may have more efficacy, but there's going to be a consequence of that, and that consequence is the safety. And one of the nice things that's why I'm so excited about research and participate in doing these trials is that's where the focus is. And we need that. Not to say the drugs we use now are overly risky, but if we can get even safer generally, because the reality is, as everyone on this call knows, we don't have a cure. These are drugs. I showed you the maintenance drugs. I showed you the maintenance data for a year. Well, that's great, and we're not anticipating these drugs. It would be an unrealistic expectation to show us a 10-year maintenance data, because if we had to wait 10 years, we would never use the drug. But the reality is these are drugs that patients will likely be on for many, many, many years. So I am so encouraged that those creating the drugs and studying the drugs have such a strong focus on the safety of them. And so that's where the more targeted you are, I think intuitively that would mean that you're going to deliver a molecule that's safer than alternatives. So that's where the consequence would potentially lie.
Great, thank you. Another question is, I've heard that with biologics, once you go off of them, you build up antibodies, making it so you can't start taking them again. Is this also the case with these new medications? Great question.
Yeah, that's a great question. So the short answer is yes. The long answer is maybe not as big of a deal. So, and I'll take them differently. So Entyvio, it does seem to be, the rate of developing antibodies does seem to be similar, maybe a little bit less than drugs that we're used to now, like Remicade and Humira. Stelara is a little bit of a different issue, that their rates seem to be a little bit lower. In fact, there was a study recently published out of McGill that actually looked at the amount. Now, and this is, I don't want to put too much faith in this, because whenever you're talking about early data, small groups, I think we need for it to play out. But there's a signal. Then in their experience, using Stelara, they actually saw a 0% chance of immunogenicity. No patients had antibodies, which is not something we've seen before. So there's some hope, and I would leave it at hope, because I can't really explain why, nor can any of the real experts, the immunology experts, explain why. But Stelara may not have as much of a risk of immunogenicity, which is the reason why, was the question, why we can't stop them, because we're worried about it, about them developing antibodies. So it may be different, but the other message I'd like to convey to you is that idea of really not being able to stop is changing. It's changing slowly because we're worried about the consequences, but we are slowly accumulating data throughout the world looking at the safety and the efficacy of stopping the drug and then restarting it when you need to. And that includes Remicade and Humira. And one of the reasons why we're feeling a little bit more confident in that is now we have other options. So when we only had 2 options, you really felt you wanted to preserve every option available because there wasn't too much. For Crohn's disease, I would suggest within the next 3 months, we're going to have 4 options, and hopefully more in the next couple of years. So one may want to take a little bit more of a risk as we understand when we can stop the medication, how to restart them safer, and the reality is if you're not successful, knowing there's many more options as we used to have. So that's a long-winded question. So the short answer to questions are probably similar, but there may be some nuances and some specifics about the way we're practicing that may change that dictum or that paradigm.
That's great. Thank you very much for that thoughtful answer. Another question is, out of the treatments you have mentioned and having the abundance of knowledge you have now, what would you best recommend a patient if they have failed at previous drugs and biologics with either having allergic reactions or the drug just stopped having its effect on keeping everything in remission? What would be your expert opinion on the treatment you feel would be most beneficial?
Okay, well, presumably, if they've been on 2 previous biologics, they've likely been on Remicade and Humira because they're the only ones available. So the reality is both Entyvio and Stelara. Well, let me take one for sure thing is if they've been on Remicade before, they should not go on Inflectra. Even though that sounds like a new drug, it's the same. Forget about the nuances of the maybe little differences. Don't go on it because they're really, really the same in all intents and purposes when it comes to this discussion. So that then leaves with one with Stelara or Entyvio. And the reality is both medications have been shown to be effective in patients who have failed a drug like Remicade or Humira. Maybe the data is a little bit stronger for Stelara, but they both seem to have some value there. So it's going to speak to a little bit about the patient's choice and the idea of trying to understand it. I'm so thankful that it took me 20 minutes to walk through that discussion about Entyvio. And you could imagine in a busy doctor's office that one won't have the luxury of really having that understanding. But now those on the call, those on the webinar, understand what that mechanism is. If one finds that as value, because the reality is convenience, Stelara is much more convenient. Having an injection, a subcutaneous injection you do at home every 2 months is much different than an infusion, I think. But some patients really would prefer the infusion. The nice thing about the infusion is it's only 30 minutes. So I think that there are things to think about. I think let me answer the question a little bit different. There isn't a drug that stands out in these 2 that I think works better. So it's all of these other, if you want to call it ancillary or other issues that you'd want to consider about what's right for you. Until we have a study that actually compares Stelara versus Entyvio or any of this, and that's coming. There are 2 trials right now looking at drugs like Entyvio compared to Remicade and Humira for ulcerative colitis. So we will probably in about 3-4 years actually know which one works better, but we don't know that now.
So one last quick question, I think. Have there been any clinical studies with pediatric patients and vedolizumab?
There's an ongoing trial right now.
Okay.
Yeah, and there hasn't been, I guess what you define as a study. There hasn't been like a randomized trial like the studies I've shown you, but there have been experiences across the world of kids being on Entyvio. I don't know how I don't know if the dose is different. Obviously, I don't treat children. I just see like adolescents and up, so we run a transition clinic. So there is experience in the world, and there is a trial. And one of the nice changes that many of the health authorities have put in place, not just for Entyvio, is one of the bars that the drug companies have to meet in order to get approval are 2 things. Many of them are told you have to have a very exhaustive, extensive safety database after the drug is approved. So they do these large studies. It's really helpful to really understand the potential risk. But then the other point is they are mandated. They have to study their drug in kids, so as long as it makes sense and it'd be an appropriate scenario, because that's one of the challenges is many of these drugs aren't studied to compete, but these will be.
How do people get involved in these clinical trials quickly?
So,
where would you go?
So you would go, so there's a couple of ways to go. I mean, I would say that, I mean, one of the options would be obviously to talk to your gastroenterologist, but your gastroenterologist may not be participating in clinical trials. So there is a very not user-friendly website called clinicaltrial.gov, which is the official clinical trial website that if you are going to do a clinical trial, you have to register it there. So you can search it. You can search Crohn's disease. I think you can potentially search the area where you live, and there may be some contact information on that website as to who you would contact in that area. That's probably the most reliable ways. I can tell you, I personally am working on actually this initiative to try to communicate to patients what in their area are clinical trials. I think it's a real opportunity because these are just some of the examples that are done. We're doing some really cool clinical trials in our office with oral medications where we're stopping the drug, you know, and then restarting it. So there are some even more, and what's nice is as we're pushing the bar, we're making these drugs safer, more convenient, and potentially more effective. So there are and the other, I think the Crohn's and Colitis Foundation actually, I'm sure there are some trials that are actually being, I think, advertised with the Crohn's and Colitis Canada.
Yeah, you're absolutely correct.
Yeah, and even if there isn't, I'm certain there's someone through the Crohn's and Colitis network that can get you in touch with the person in your area that's the go-to person.
That's right. Well, I guess that brings us to an end, and thank you, Dr. Bressler, for presenting today on this very relevant topic. I would also like to thank our participants for your questions and comments, and to AbbVie for supporting this webinar. We will be following up with all the participants via email to get your feedback and any suggestions you may have for future topics. And we will also be sending you a link to today's recording of this webinar. So thank you very much for joining us, and this adjourns our presentation. Have a wonderful evening.